I'd like to welcome everyone who's attending this virtual CME this evening. Thank you very much for those who've been able to be here physically and those who have also logged in virtually. Today's presentation is going to be on failed spinal, anesthesia for Caesarean delivery, mechanisms and management. Our presenter today is Dr. Ngugi Kigera, who is a lecturer at the Kenyatta University School of Medicine. He is a co-founder of the SC Health Specialist Clinic. Dr. Ngugi is a pain management specialist and anesthesiologist with particular interest in improving access to specialist pain management services for our population. He has over 14 years of experience as an anesthesiologist, and he has a clinical training in interventional pain management from the Medical Center in Tel Aviv, Israel. And he's become one of the handful of pain specialists in sub-Saharan Africa. This practical background was a starting point of his increasing engagement in regional anesthesia and pain management and pain medicine. He has facilitated many workshops and trainings across Africa in the areas of regional anesthesia and pain medicine. Currently, he is focused on efforts to improve pain management training of anesthesiology residents across the 9 countries who make up the Eastern, Central, and Southern African region. So without further ado, I'd like to welcome Dr. But before I do that, I'd like to, for those who are joined virtually, in case you have any questions or comments, you can post in the virtual box, and we're going to have a question and answer session at the end of the presentation. Also, Troika, our sponsors, we have all their material around us, so they're also going to give us a presentation at the end of the talk. So, Dr. Ngugi.
Thank you, Dr. for the kind introduction. Well, so I stand humbled, or I'm humbled to be in front of you to discuss about this particular topic that, depending on who, it's maybe something relevant. So without taking too much of your time, I'll just move on. So today's talk is on failed spinal anesthesia for Caesarean delivery, and specifically on mechanisms and management. On this particular talk, I have no disclosures or any conflict of interest on the design of this talk. So just hitting the nail right on the head, has anyone here ever had a spinal that for some reason didn't work? Yeah, so I guess it's one of those things that are quite common, or let me say that they do happen. So why spinal anesthesia? We know that the worldwide move for the last 20-30 years is that for Caesarean delivery, spinal anesthesia is the preferred technique. Did it happen by accident? No, there are various solid reasons why. One, it has a safety profile better than general anesthetic, meaning that GA does have a few technicalities in terms of complications. And the other good thing about spinal anesthesia, it also has high reliability, meaning that it does work almost all the time. The other thing we've seen is that spinal anesthesia is also a quality marker, depending on your departments. If you go rate your spinal anesthesia rate, gives you a marker of quality. That is something accepted. So you can always go back and check how well your department is doing based on spinal anesthesia rate. The other thing about spinal anesthesia, it's easy because the endpoints are hard endpoints. So let me say they are easy. Why? We can see that needle insertion is usually not too complex. The other thing is that we need CSF to flow. That again is something you can see with your eyes easily. All these points make spinal anesthesia the desired method for Caesarean section. And it was, you think that spinal anesthesia, you know, with its complexities, that it's something we've noted recently. So this gentleman, this we're talking now 101 years ago, very famous guy. Maybe someone knows which country he came from before he moved to the US. So Gaston Labat in 1922 actually ably summarized that you need two particular conditions for absolute to produce spinal anesthesia. One, you need to be able to puncture the dura. What does that mean? You get CSF. The other one is you need to inject anesthetic agent. So those two conditions 101 years ago, are they still relevant today? So relevant, even 100 years down the road. So when we mean failed spinal, what do we actually mean? What's the definition? The funny thing is when you go into literature, there's no standard definition for failed spinal. What do some people believe? Or in literature, what have they, how have they approached the idea of failed spinal? One is that if you, for any reason, convert to GA in a patient where you had stuck a needle in their back, that is considered failed. GA, remember, can be before the surgery, or sometimes you've even started the CS has started, but for some reason you convert to GA. Another definition you'll find commonly in literature is that if for any reason you've had to give ketamine, you've had to give fentanyl, you've had to give Entonox, you've had to finish with local anesthetic in as much as you didn't intubate the patient, that also constitutes failure. Some papers define failure as just having pain during surgery. So you need to add something to this. So as you can see, because of that, we're depending on which paper you're reading, you'll end up with a different failure rate. Other papers have described it as when you don't get any CSF. Others where it's either total block or even inadequate sensory level. Some literature has defined failure as sometimes when it is patchy or not adequate, doesn't last the distance, doesn't rise to a particular level. So because of that, we end up with worldwide having different variations in incidence of failed spinal. So just looking at my colleague called Dr. Nabukangwa Simiu, she did this paper in the KNH 2015, and she looked at patients 576, and her definition of failed spinal was, she went on the side of success. What is a successful spinal if no GA was given? So for her, failure was if there was for any reason to convert to GA. What was the incidence at that particular point in 2015 was 5.4%. And in those patients, we got almost half, 41%, 42%. They converted to GA within 30 minutes. And the rest after 30 minutes. Mean dose in that particular study was 7.5 milligrams. When they assessed sensory level in about 35% of patients, it did not ascend to T4, T5. If you look at association factors for failure in her study, there was no association with emergency, the CADA or provider, or experience, or obesity. And when they looked at the type of bupivacaine that was used, actually all the failures did not happen in the hyperbaric group. Looking at position, most failures in that particular study were in patients who are where the spinal was done in the lateral position. So what do you say about this thing? Where experience CADA? Probably it means by first year we are training residents so well that consultant resident outcome in terms of spinal anesthetic is, it doesn't matter. Also probably means we need to do something about position. How do you compare with the Dr. Kimberly Kamau's paper of 2014, the year before, again at KNH? She looked at 196 patients, majority were emergency. Her failure rate was a bit higher, almost double, 9.7%. And what was the definition of failure for her was a repeat spinal, if there was conversion to GA, so it was a composite measure, or if high-dose ketamine was given. So you can see a definition of failure a bit different from Dr. Simiu's. Use of McCain again varied. We had about 24% on hyperbaric. Repeat spinal cases did occur, and in those ones, it were basically in patients who had 5 milligrams given for the CS. And risk of intraoperative pain for her study, they found it was in patients who had a sensory level of T6 and below. So there are many papers across the board. I won't belabor so much, but failed spinal is common. This one from South Africa. Again, a failure rate of 11.7, depending on definitions of failure. In Nigeria, another paper. This one, again, failure of around 6% with the definition of failure. And a famous paper by Kinsella in the UK, again, looked at this tertiary hospital. Looked at cases in excess of 3,000. Failure rate was 6%. Definition being intraop conversion to GA, sorry, pre-op conversion to GA or intraop, GA, or even supplementation. For them, a few differences. Majority of our papers, most patients, CS was done or the spinal was done in the sitting position. In the UK, most of the patients were done their spinal in the lateral position. The doses was 2.5 ml. We're talking 12.5 milligrams with morphine. Yet the failure rate was at 6%. What were their associated factors? They found failure was higher in high BMI patients, in patients who had no previous sections. Patients who had previous sections hardly failed in that particular study cohort. Again, failure was associated with acute fetal distress and in the emergency setup more than elective. So Singapore, again, another failure rate of around, we're talking almost 1%. So failure for spinal is worldwide. It's not just in Kenya, not just Africa. Papers, you go back to US. So it's a topic that affects the whole world. Looking at recommendations of what should be our CS rate, looking at recommended failure rate, they say for electives, probably if you should be doing around 1% to 3% for emergencies. But in literature, even in high-income countries, we find, depending on definition, failure rates going all the way to 17%. So when a spinal doesn't work, what could have gone wrong? Usually, in all those studies, a few themes come out based on three main areas. One is on clinical technique. Another one is inexperience, in as much as the paper from Kenneth showed there's no difference, but majority of the papers, when they've done systematic reviews, they find that experience is a factor. The other one was failure to appreciate a meticulous approach. So these three factors are the main themes that have been associated with spinal anesthesia. I'm sure maybe someone would have thought another factor, but let's move on and see. So for spinal anesthetic, if you look at if you are to break down the steps or areas where these three themes have affected, where the technique may fail, is either during the lumbar puncture itself, during injection of the solution, during spread of the drug through the CSF is also another factor. The drug action, so it can go in, spread, but again, for some reason, maybe it doesn't work. And the other key thing is, which sometimes we forget, is about subsequent patient management when we think maybe it's not worked. So the 5 areas are key in terms of understanding mechanisms of why spinal anesthesia doesn't work for CS. If you look at failed lumbar puncture, what you're saying, maybe you've had a dry tap, you've been sticking the needle in there, sticking it, and you can't find that, you can't puncture the dura. What could be wrong? Sometimes it's patient positioning. We've seen difficulties. Maybe a patient is moving about, maybe they're so grave that can't assume the position that is required. Or maybe because of the table, you're trying a lateral position, you can't get the mattresses are sinking in and so on and so forth. The other one is also about incorrect needle insertion. We've seen, especially with trainees, how they put in the needle that sometimes it doesn't go in the direction. Remember the orientation of the lumbar spinal processes and so on. What are the associated factors for a failed LP or failed lumbar puncture? Spine abnormalities. It's common when you see these patients with scoliosis, some of them difficult obesity, you can't feel the landmarks. The needle goes in, you're not sure where you are. And of course, I'd mentioned patient anxiety or a patient who is moving. How does positioning affect? We've seen in our setup, most patients get their spinal anesthetic when they are in the sitting position, because it's thought in the sitting position sometimes may be a bit easier to identify the midline. But again, this varies from hospital to hospital. Some hospitals, almost all their patients get their spinal anesthetic in the lateral position. So ideally get a surface that's firm and the position and get a good assistant. This we know. We struggle in the hospitals where the assistant doesn't know, is clueless. They're just looking at the patient and so on and so forth. So those sometimes contribute to not having the right position and you struggle to put the needle in. What about needle insertion? Always keep in mind that in a few, up to 20%, in fact, some cadaveric studies have shown up to 40% of patients, adults, that the cord can actually terminate below L1. So always keep this in mind, especially where landmarks cannot be easily palpated, because we know a needle into the conus medullaris is a lawsuit. Okay, it's yeah. So we also know Tafia's line, again in pregnancy, is not a very accurate measure. People have had it wrong up to 40%. Again, needle redirections, if you're not so clear, and this is especially for the trainees, not understanding the 3D nature of the spine, and not understanding that if I put my needle and encounter bone, then maybe I redirect my needle in a particular way, encounter bone, have I moved further on or moved, or I encountered bone earlier and so on and so forth. So these are things which come with practice. So for a successful LP, which is the first step of what you'd want to avoid, prefer to have a relaxed patient as much as possible. Things which may help is explain. So in patients, you don't explain, you're splashing skin prep on them, they're moving about, they don't know what to do, they don't know what to expect. So explanation has been shown to help with anxiety. LA infiltration, up to a few years ago, some people didn't believe in infiltrating local anesthetic before, and patient ends up jumping and moving, leading to some of these failures. So deep infiltration. I know there's a fear of distorting the anatomy, but please, it's been shown infiltration does help to keep a patient calm. Sometimes there's room for provision of anxiolytics in certain patients, again with caution. A technique you should, maybe just a quick show of hands. What's your, how many, when midline doesn't work, go to lateral? Just curious. And does it yield results? Or sometimes in the midline position, still in the sitting position, and you move to the paramedian location to try and get your needle in, right? Yeah, so paramedian incidentally is easier than midline technique. Midline technique, you need that tunnel, that little tunnel of the spinal processes to direct your needle through. Paramedian, we don't have spinal processes. So you can walk your needle on the lamina and enter the dura more easily, but of course needs some practice. So it's the first time to try on that difficult obese patient. But it's something I think people should embrace more or learn more, so that becomes a go-to technique when it doesn't work. So advantages in the obese patients with scoliosis. It's been shown in patients, in people who do paramedian versus midline. Generally, paramedian have first pass success compared to midline, and they have fewer needle attempts. And the goodness, patient doesn't even have to flex so much because there's no spinous processes to open. So even in that position, it's easier to penetrate the dura, and so many advantages, even in the epidural, if you're placing an epidural. So this is what I mean, that with the paramedian or paraspinous process, you'll find that you can angle your needle so much further. There's no spinous process in the way compared to how you are restricted in the first image with the usual midline technique. So it's a secondary, you can have it as your plan A, but it's something good to have. What about obstetrics? There's been an explosion in, what about ultrasound? There's been an explosion in the use of ultrasound in medical, from putting IVs, central lines, arterial lines, nerve blocks, and so on. And the same thing for spinal anesthesia. What does ultrasound do for us? One, in patients where it's difficult to either palpate because they're obese, they have spine abnormalities. We know some of the obstetric patients have edema in the lumbar area. Some have suboptimal positioning. What can ultrasound do for us? A few things. One, we're able to identify the space. Just count from the sacrum. You can get to your L4, L5. So where you're not sure your taphia's lying, you palpating can't tell, ultrasound can show you the interspace. Can identify the midline. So even though there's scoliosis, rotation, or otherwise, you can easily tell midline. You can estimate the depth. So you can, assuming in hospital you have selection of needles, you have these obese patients. So you can actually say, hold on, my estimate to ligamentum flavum dura is 9 centimeters. So I'll choose a particular needle. And because it can identify rotation, you can actually know where to put your needle and the direction. And it doesn't matter if you're doing midline or you're doing paramedian technique. So because of that, there are certain advantages: less needle attempts, reduced failure rates, safety, because you don't want to do multiple attempts in a patient you can't feel taphia's line. You also improve patient comfort. No patient wants to be stuck at their back 10 times. It's just images, but I guess this is something we can do in workshops. I've seen lately in the last maybe like 10 years or so, there's no conference without a spine ultrasound course. So it's something I guess we should be doing more often. I think almost many hospitals now do have ultrasounds in theater. So sometimes what happens when you do get CSF and maybe it doesn't work, sometimes what is called a pseudo successful lumbar puncture, where you get clear fluid, but you're not actually in the subarachnoid space. So what can explain that? It's a rare phenomenon, but can happen especially in patients who've come with an epidural. So a patient has had an epidural for labor, but you've tried to convert that for anesthesia, maybe it doesn't work so well, so you decide to do a spinal. Sometimes when you get that flow back, it's actually the local anesthetic, which is in the epidural space. So just something to consider. There are also patients who have meningeal cysts. Others do have congenital arachnoid cysts. They are rare, but they're just some of those anatomical differential issues that may affect why you get CSF return and not necessarily get a working spinal anesthetic. Another key thing that has been noted in literature is what we call solution injection errors. You've seen lately what tranexamic has done to patients. So sometimes people accidentally may pick the wrong medication. So wrong medicine, being inert in terms of a local anesthetic. So in this particular case, you've had your CSF, but you've injected something, it doesn't work. So either wrong medication. And remember, the science is that you must have an effective dose to be deposited in the CSF. So those conditions must apply. Sometimes you do get CSF, easy LP. You inject your medication. You're probably not having those anatomical abnormalities we've talked about. So what could some of the reasons be that may affect spinal tick? One is intrathecal drug spread. This is paper that the dose at subarachnoid is influenced by certain things. One, the dose does influence the quality. So put a higher dose, it means you're more likely to have a denser block. Put less than normal dose, likely to have a not so good block. And also duration. If the surgery takes longer, you put less, it means that it may wear out before the surgery, and then you end up having that criteria you've seen, people converting at 30 minutes, at 45 minutes, and so on. But what we know is that within normal dose range, dose has little influence on spread. So there's sometimes some people say, I don't give so much because I fear it will go up. But generally, what is in literature in terms of normal dose, that has most of the time normal should have little influence on spread. So when you select dose so that you want to have this good intrathecal drug spread, what are some of the things you should consider? Choice of LA. We've already seen in failure that sometimes there are differences between isobaric, hyperbaric, depending on which paper you are reading. Patient positioning, because we know that with hyperbaric, you can actually play around with gravity to move that medication. Nature of block desired, as I've said, you want a higher block, you want a lower one, you can actually select or do some things for the patient. And of course, extent of surgery. We've seen duration of surgery does affect. If you know they're likely to start doing tubal ligations, things which may make the surgery a bit longer, probably these are the kind of patients you want to go on the higher normal than on the lower normal. So briefly about dose selection. Generally, we know that the standard, what is called the single shot dose, usually are larger than is necessary. Most of them we are working on the ED 95. How did we know, it's not always that you need that high dose. We've seen this from continuous spinal anesthesia studies, people with a catheter. So what are the advantages of low dose? We know that we get less hypotension, faster ambulation, less need for catheter in lateral block, especially for orthopedics. So if it has all these advantages, why don't we stick to the 5, 10 milligram route? It's because there's also the other side of the coin. So how come recommendation is on the higher side, even when we know lower can work? Is that sometimes you need this margin of error. You've seen many times injecting a drop, a drop comes off at the hub, you stick a syringe there, sometimes, 2 drops or something. So that margin of error is important because the less you put, it means if you even lose any little amount, you get problems. So you reduce risk of failure and again, imperfect spread. So looking at the papers, at least the ones for KNH and what could see, the paper by Dr. Simiu, that the dose range was 7.5 milligrams on average, failure 5.4%, actually just 35.2 achieved T45. So meaning 2/3, close to 2/3 of patients did not achieve, what is usually the recommended target. And because of that, we saw that 58.1% of the people who had failed, actually the conversion happened early, within 30 minutes. Let's compare that with the paper by Dr. Kamau, that 91% of patients got a low dose again, less than 10 milligrams, failure 9.7%. They looked at block at the ascendancy, and they found that patients who had T6, of course, ended up having intraoperative pain. And in Dr. Kamau's paper, the patients who had failed, some got a repeat spinal. And those ones who did get a repeat spinal, actually, it worked. So what do you infer from that? It's probably for these failures we had, probably, I won't say it is certain, but probably the failures that occurred, many could have been avoided by having larger dose, because we've seen the lower side, any small issue leads to higher risk. Okay, looking at loss of injected can occur with connections, and this is very critical if your practice, you use low doses. So be super, what we talked about, meticulous technique. If you're going to use low dose, ensure your technique is meticulous, not that you can't use it, and you avoid loss, because even a few drops may mean something. What about misplaced injection? Can occur because of displacement of the needle tip. During injection itself, you can get CSF, but as you inject, you get some movement. The patient is anxious. There's no local put-in. Maybe patient moves for a contraction, anything. You can get displacement of needle tip. What if you aspirate? Is that good enough? It's been shown that yes, aspirating is good enough, but is not a guarantee that just because you aspirated back CSF, that you're necessarily in the right spot, or the injected will go in, and I'll show you images. There's this image from Naesthesia, which shows, especially when you're using the pencil point, that sometimes the opening, as you aspirate and the needle moves slightly, you can still be able to aspirate CSF, but when you inject, you get that some of the medication enters subarachnoid, but some of the injected ends up being in the epidural space. So you qualify everything, LP, check, CSF, check, right dosage, check, but you injected some, for whatever reason, the needle may be displaced. And this you can't tell. I mean, you don't have eyes inside there, but it's been shown. Another way is sometimes the dura may act like a flap. What does that mean? It means when you are aspirating negative pressure, the dura opens, the flap opens, and you get CSF. But when you inject, the dura flap is pushed, and all the injected ends up going in the epidural space. So all these are some of the things. Sometimes you have everything check, 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 but sometimes you don't get a spinal that works as you want. I think we've covered a few things about intrathecal drug spread. I won't go too much into that. What of solution density? There's always a big fight in every hospital. I can never use some can't use plain, some can't use heavy, yet we're all using them in the same hospital. So what's there in literature? Actually, depending, some say no difference, but some say there is a difference. But there are a few things where physics comes into play. What are some of those things? That ideal isobaric has little thoracic spread, that we know. But what happens at isobaric at body temperature may become hypobaric. So 37 degrees CSF sometimes, and we get what is called the unpredictable spread. This you already know, I think from books in MED. You could see one picture spread all the way, and the other one stays relatively put. Hyperbaric, on the other hand, gives a more predictable spread. And because of that, some papers show a higher reliability. So, yeah, but if it works for you, well and good. And this reliability gives us some ability to move it. It means we can influence with gravity how we position our patients, depending you're feeling, it's at T10. I want my block to go to T6. You can actually manipulate your patient and so on. Sometimes the injected, depending on where your needle is, like sometimes you get a nice L4, L5 position. You want to put your needle there, L4, L5, well and good. But in some patients, you may get trapping of the injected due to the shape of the spine. So the patients, while compared to, say, if you inject at L3, L4, so just something to keep in mind. Sometimes it doesn't work. Could there be injected getting stuck there? The goodness, if it is isobaric, is what you can do to the patient, and the medication moves. Drug failure. There have been instances where there's a thought of drug failure. what has been shown so far, we have many reasons. Some is incorrect drug, make noise, then you come later on and find, wow, my McCain is still on the table and it's not in the patient. Sometimes you have physicochemical incompatibility. When do these arise? Mostly when you have mixing. Sometimes there's chemical reactions with some of these adjuncts. Sometimes when vasoconstrictors are put in there, sometimes do change the chemical properties. Sometimes you have inactive local anesthetic. Some patients have even been postulated as what is called resistance to local anesthetic. Inactive local anesthetic most of the time is because of storage. We know that sunlight and many other conditions that may not be appropriate may lead to some areas being inactive. Which groups are mostly affected? More the esters than the amides. There was a time where anytime I got a failed spinal, I say that the drug can't be anything else. It's that medicine. I don't want it. And I went back to literature to check, because I thought if everyone gets a failed spinal, then bad drug must be very, very common, because that's what I thought. That's what many people around me thought. But when you go to literature, there are people who actually check this out. And most of the time, it's when it occurs in clusters, meaning that this week, you probably had like a number of failed spinals where previous weeks before, nothing was, everything was right. So whenever they've had these unusual patterns of failed, some people have actually gone on to take that medication for testing. I'll just give you one in the UK. And they had 5 cases, and over time, they even mentioned the brand. There's a paper there. And when the drug assay went to the, when it was assayed, they still found it was okay. But the funny thing, when they changed the batch, things went on okay. Another paper in 2016, similar thing, that patients are getting patchy blocks. Again, 3 cases in 1 week in a place where you're not usually getting cases. And they found that, again, sample batch taken to manufacturer for analysis, they didn't find any problem with that batch. Another paper, 24 cases over 1.5 years. Because I got really worried. Even FDA came into play, went for test, and they still found the same thing, that drug is adequate. They changed manufacturer, like, yeah, don't want that manufacturer, I'll bring another one. Change Potex, failed also. I mean, the occasional fails were there. Change to AstraZeneca, occasional fails. So what are some of the possibilities? So you could find, they were trying to reason. Assays are okay, we're still getting these unusual clusters of failure. It's not our usual pattern. So some of the things they, in literature, summarize that we do understand that every now and then a technical error can occur with spinal anesthesia, and it is the nature of individuals to deny to others and themselves that such errors occurred. So sometimes, at least in literature, it's not been proven. It is the molecule. Maybe in future, who knows? But so far, other reasons, and you've seen from this presentation, there could be a myriad of reasons why sometimes spinals don't work. So I'll just jump that. Drug failure in Kenya. Who knows any brand that has never failed? I'm sure the one I'll say has never failed. The funny thing is, to my next person, he'll say, no, that one failed on me sometime. So what am I trying to say is that generally in the market, we've said that almost all molecules have had a problem. But again, even some have been taken for checks. I think there's one which was taken for checks some time ago. They still didn't find anything weird about it. What about the concept of some people are resistant to local anesthetics? Again, it's happened, but it's still not accepted as an entity. They've looked at the sodium channels. We know how local anesthetics works. It's pass most of the literature comes from dental clinics. This guy is injected in the tooth to extract. For some reason, it doesn't work. And they've tried to assess what could be the reasons. Could it be technical failure, like we've seen may happen? Infections, abscesses, which interfere with the pH and pK. So again, in those patients where it's not worked, they've tried to take the same LA that didn't work, injected it under the skin. And for some reason, in some patients, in most of them, they actually had, they were anesthetized now on the skin, even when it didn't work in other areas. So that's why the concept of LA resistance is not widely accepted. So they've been in multiple case reports, or maybe there is resistance, maybe. Interestingly, there was this patient, 50-year-old female, who had an MRI for transverse myelitis, attempted LP. They infiltrated up to 15 ml of 1% lidocaine. This woman was in pain, even when they're trying to do the LP. This woman had history of prior fails also at the dentist. And she also reports that her father also had fails at the dentist. Hopefully they didn't go to the same dentist, but so these are some of the case reports that come into play and bring that doubt or bring the idea. Probably there are a few patients who may have some resistance, and multiple papers which have looked at changes in some of the sodium channels. Maybe I just jump from that. So the last point about mechanisms is about failure of subsequent management. I know that would be like, how is that a failure? But actually it's because some of these things can be rescued adequately. And this is important. There's a paper I forgot to put in South Africa where they compared outcomes of Caesareans, patients who are GA and spinals. And the funny thing, they had poor outcomes in the spinal group. But on deeper analysis, all those poor outcomes, majority of them were because they had failed spinal and they were being converted to GA. So it's something to know that failed spinal being converted to GA in some areas have been associated with poor outcomes. So it's something to know about how to manage in case there's failed spinal. But there's a rider that not all claims of discomfort or pain are the results of an inadequate injection of spinal that's not working. One, you really need to explain to your patient what to expect, because there are some who are so anxious that they perceive any touch, even where they're not anesthetized, as pain. So it's good to be clear, explain what to expect. Sometimes because of overactive or now parasympathetic system, which is not being counteracted by the because of sympatholysis. Sometimes anxiety on the part of the practitioner, not the patient. You've seen those patients, those put in the spinal every 2 minutes. Are you feeling this? Are you feeling this? Can you feel this? Lift your leg every 2 minutes. What that does is induces anxiety also in the patient. So patients start to, sometimes it's even imagining, and that anxiety is a problem. Just so usual, we know spinals take 10, 15, even up to 20 minutes. Take your time before every minute you check. And because of that, they've said that when patient management certainly has failed, if such a claim is made when the block is actually as good as it could be. So block is working, but for some reason, trying to shift to another method. So approaching management of failed spinal, we have that small risk of failure. Again, we said anywhere 1% to 17% depending. So because of that, it's important to discuss at consent. We have these patients, sometimes you come and say, yeah, I'll do for you spinal. And then they end up being that 1% where you have to convert. And they're very unhappy because that was not their plan. So at consent, always mention that it works. The best, it works 99%, but who knows, it could be the 1% where it may not work. So promising everything will work, of course, is unethical. And because of that, always remember, failure is distressing to everyone. It's not just to the anesthetist, also to the patient. So that's why that consent process must prepare a patient that in sometimes, even with best hands, it does fail. So when you manage a failed spinal, what are the two key factors to look at? One is the time at which failure is detected, because depending, if failure is detected before the surgery, there are a few things you may do a bit different from when it is detected after surgery has started. And again, the nature of the failure. Remember, there is no to patch it, take, and so on and so forth. What about time? By what time do you say, I think I've waited enough? Because usually those like wait some more, or yeah, no, I think. So generally, if by 15 minutes, still have a Bromage score of 0, patient still kicking everywhere at 15 minutes, generally, the chance it's a successful block is very, very slim. So what happens? We said nature, if there's no block, put in your medicine, 15 minutes gone, always go check back. Is it wrong medication I gave? It happens. Could it be those anatomical things we're talking about? Lastly, could it be the ALA didn't work? So what are the options? You can either go GA if there's no major contraindications. Again, you can also repeat spinal. We saw in Dr. Kamau's paper that the repeated spinal and all of them worked. But what if the block took, but you check your temperature, sensation, touch, it's not adequate, it's T6. Like we saw in the other paper, T6, all of them had intraop pain. What can you do? Possibly, maybe some of the injected is misplaced, maybe abnormality. Some people have sat down those patients or turned them lateral position, put in an epidural because it's an elective, maybe there's still time. Another one is wound infiltration. Those few patches sometimes can be infiltrated and the surgery can be finished. So you can see there are quite a number of steps to be taken. So repeat spinal itself does have its issues. Again, no consensus in the world. What to do? Do you repeat everyone? How much do you repeat, and so on? Don't repeat ever. So many things. So let's look at what is in literature about repeating failed spinal. There have been cases of, again, few cases. There are many people who get repeat spinals, but sometimes things go wrong. One has been cases of quadriquina. This one's because they had continuous SA, spinal anesthetic. What was the cause? We know local anesthetics, even when they work, they can be neurotoxic. So sometimes when you have a very high concentration of local in a small place, that can be at a concentration so high for those nerves that they end up having problems. So codequina has been noted, and because of evidence of sacral accumulation in this particular patients, and this will happen because of those repeat spinals. So there's a risk that repeat spinals, you have a very high concentration of local anesthetic in the CSF. With that trapping we had talked about, before you do a repeat, it's always good to check sacral dermatomes. I've seen like when you do, sometimes assessing sacral dermatome is not what we usually do, but it's good to just go under there, feel the S2, S3 area. Sometimes they're anesthetized. It's hyperbaric. You can just flex their knees after that, turn the table, 5-10 minutes, and you get a good spread. So before repeating, it's good to assess sacral dermatomes because of trapping of the injected. For repeat, some people advocate you alter position. Maybe you put the needle, change baricity. And many people advocate do not repeat full dose or repeat full dose in exceptional circumstances because of what you have said, that if a full dose was given, you give another full dose, there's an unlikely episode where you can have very high concentration of local anesthetic in that lumbosacral area up to toxic levels to the nerves. So as I mentioned in the Dr. Kamau paper, 2 cases of repeat spinal, all had good effect for surgery, and they had no reported neurological problems. Maybe just looking at another paper just compares the dose of what was repeated. So this paper, they didn't qualify clearly, or they called a failed block, where in 10 minutes, there was no take. That's what they qualified their failure, and they repeated. One group, 10 milligrams, another group, 12 milligrams. What was the outcome? Is that all achieved a good block for CS, but there's a safety concern because in the ones of the higher group, 6%, there's a big difference between 0 and 6%, 6 times. The ones in the highest got a high spinal. They required more atropine. They required vasoconstrictor more than the group that had a lower dose. Yet all of them achieved the effect of anesthesia. So just means if you have to repeat, possibly repeat with a lower dose. But before you repeat, as I said, assess for that restricted block. Remember, there's a chance of a high spinal or toxicity, so use a lower dose. Watch out to the level, the dose. So for success of spinal, again, just in a nutshell, right place, right drug, right dose. So in conclusion, this talk is that in failure points are this one, either at LP, injection of the drug, spread, or drug action on nerve roots and spinal cord. So thank you for listening to me. Give it back to Dr. Wera.